Yes. Good morning. On behalf of Sun Pharma, Pharma Care Division, I would like to extend my warm welcome to all the delegates for today's webinar and a warm welcome to our respected speaker, Dr. B. Jayaprakash Reddy. My name is B. Mahendra Varman, DGM, taking care of pan-India operations of sales in Pharma Care. Pharma Care is a division of Sun Pharma which deals with the products like Cipodum, Riconia, and Bexilus. Before I start the webinar, my big salute to the entire medical fraternity, which is doing a great service to the humanity by sacrificing their family life, in some places even their life, precious life as well. It is my privilege and pleasure to present the testimony of Dr. B. Jayaprakash Reddy, who is a professor of ENT, consultant at Sri Satya Sai ENT Hospital, Kurnool, AP. Dr. Jayaprakash Reddy has big contribution in the field of managing trachobronchial foreign bodies, and he has got 17 gold medals to his credit at various levels. And today we'll have a webinar from Dr. Reddy, and I think definitely there will be a lot of take-home messages. And over to Dr. Reddy. Yes, sir.
Yeah, good morning, everyone, and thank you, Dr. Mr. Mahendra, for your nice introduction. And good morning to all the viewers. See, we are going through a very tough time now, the whole medical fraternity, and we're all sitting at home in spite of our busy schedules in the past. So now it's an ideal platform to share some of the experiences and of ours in the practice, and so that it will be of much use to you in the days to come. So today we have selected this topic of foreign body in the pediatric airway and its management for the simple reason that foreign bodies in the tracheobronchial tree are always been a challenge to the treating ENT surgeon, because it poses a lot of problems intraoperatively and postoperatively. So in this presentation, I will be sharing my experience of managing around 1450 tracheobronchial foreign bodies for the past 20 years. So before I go to my presentation proper, it is the right time to remember my my alma mater where I studied ABCDs of medicine. This is a place where I studied. This is Adichunchanagiri Institute of Medical Sciences in Vijayanagara, Bellur, Karnataka. And this is my place where I studied my post-graduation, that is MSc at Bangalore Command Hospital, where a lot of exposure we had about the bronchoscopy. With this, we all know that there is a lot of importance surrounding the foreign body bronchus in a child. Why so? Because the airway is very narrow, as we all know that. If you do slight manipulation more than what is required, it may lead to subglottic edema. It is very dangerous, and it is not so easy to do instrumentation in a child as in like an adult. And last but not the least, airway has to be always shared with our anesthetic colleague, and that poses a lot of issues. And mind you, and I just want to tell you that the pediatric bronchoscopy is much safer today. See, in the earlier days, they used to take maybe around 30-40 years back. If you want to do a bronchoscopy in a child, they used to take consent as a death may happen on the operating table also. But today it is not the same. We are having much better improved anesthetic techniques, and we have very good armamentarium of instruments available to us, like ventilating bronchoscopy. Earlier days we had only Negus bronchoscopy, where we have to have distal illumination or proximal illumination is there, and airway was not seen very clearly. Nowadays we have very brilliant optics, telescopes, telescopic forceps, and improved anesthetic techniques are all put to pediatric bronchoscopy is much safer today. We don't tell the parents that the on-table death may be a possibility, but there is a meager chances are there for any complication to occur. But it is not so much dangerous situation as in the earlier days. See, when we say bronchoscopy, it's two types. Number one is the fiber optic, that is mainly used for diagnostic purposes when the patient has a tumor or a cough, when you want to have a bronchoalveolar lavage for studies. Foreign body fiber optic bronchoscopy usually done under local anesthesia by pulmonologists or intensive care specialists, or for anyone who is involved in that they are doing. And rigid bronchoscopy is mainly done for therapeutic purposes to remove the foreign body mainly by ENT surgeons. And this is the man who did a lot of his work, and he is the man who spent his whole life in describing the technical bronchoscopy and describing a lot of instruments that are required to do bronchoscopy. And the monogram that he had written or authored so many years back, this is bronchoesophagology by Jackson and Jackson, is still, I consider that this is the Bible for us. And every line that he has given is fantastic. It is a must read and must have book for everyone. I suggest this book for everyone, those who are involved in tracheobronchial foreign bodies or esophageal foreign bodies. This is a book that must be read. We all agree that foreign body in the bronchus in a child, it is very common. But why? When you compare with adults, see, out of all these things, lack of molar tooth, because that they cannot grind the nuts, and poorer mastication, and all this playing tendency and playing with the mouth. But this immature, see, the God has given us 3-tier protective mechanism to us, so that anything that we keep it in our mouth will not go into the lungs. The 3-tier protective mechanism, the first tier of mechanism is with the aryepiglottic fold, the second one is with the false guard, and the third one is with the true vocal cord, which are very, very protective, so that nothing will enter into the tracheobronchial tree. If all this fails, or if the protective laryngeal reflexes are incoordinate or immature in children, then that is the reason the foreign bodies are very common in children compared to the adult. So out of all my presentation, I can tell you that this is the one slide which is very, very important. I draw your attention, please. See, when we suspect a foreign body in a pediatric airway, these are 2 instances. Number one, when a child is brought to you or referred to you by your pediatric colleague or somebody with a history of choking while eating, that is called as positive history of choking. When the patient has a history while eating something, the child had a choking, that is coughing, and then the child has become all right. This is very, very important. Then followed by that event, then the patient has cough and wheeze, and when you auscultate, there is a decreased absent breath sounds. This forms the complete triad. Then without any doubt, I can tell that this patient is having a foreign body in the tracheobronchial tree unless otherwise proved. So in this type of scenario, you just take an X-ray and then go ahead and remove the foreign body if it is there. Many of the times with the history of choking, foreign body is there. In the second scenario is that when a child has a persistent respiratory symptoms, like patient has persistent cough, breathlessness, and patient is moving from one pediatrician to another, one doctor to another, and it is being treated as asthma or allergic bronchitis or pneumonia, tuberculosis and whatnot without any relief. So these kind of patients, we have to keep a suspicion that the child may have a tracheobronchial foreign body, and it warrants a complete investigation, and it has to be referred to the proper place. So this one should not miss. So whenever a child has a persistent cough, breathlessness, you have to, with treatment it is not getting controlled, then I think it's a good idea to get a X-ray and then do further investigation. And in this patients, you have to ask that you elicit the history of choking. So sometimes the child or parent, the siblings or somebody would have seen the history of choking, which was not given much importance to that. So you need to elicit that history. That's very important, so that we can. So by the time the child comes to us for the bronchoscopy and foreign body removal, there's always a delay. Why there is a delay in presentation is that there is a part of the parental negligence, or it is misdiagnosed as asthma, lower respiratory infection or tuberculosis and so on and so forth. And there is a lack of suspicion on the part of the physician or ENT surgeon. And we ourselves sometimes we procrastinate. There is undue procrastination from our side. We delay the patient referral, so that all these points, then there is a delay in diagnosis. So when the child will present with wide variety of all the symptoms like this, but most of the times cough is the predominant one. So without any patient, without having cough, I don't think I'll suspect a foreign body in the bronchus. Cough is the first symptom to have that is persistent, and breathlessness will be there. When you examine the child will have a unilateral wheeze. So that's very important, unilateral. And child may present with pneumonia or surgical emphysema. And in emergency, like whenever the child has a foreign body in the glottis or subglottis of trachea, the child may present with severe breathlessness and sometimes cyanosis, collapse, and all those things. So we'll just have a look at how the child will present in different scenarios. See, now you can see this child had you can see the breathing here, how the child is breathing, labored breathing. You can see this child had a subglottic foreign body, which was removed immediately upon arrival. So this is how the child will present. And you see this child had severe breathlessness. Practice. The child had a bilateral bronchial foreign body. You can see how the child is struggling to breathe. The child, and we are ready by then. We have removed this foreign body in a matter of 5 minutes. This is the telescopic process I am using. I am trying to record my event, but the anesthetist said stop recording and just remove the foreign body because if there emergency we cannot wait. So now I removed my telescope and then I removed the foreign body. Very small. It will not take much time, and so once the anesthetist takes the priority over us, so we have to listen to the anesthetist. So you can see this patient was presenting to me at late night at 1 o'clock in the midnight. You can see the child had a foreign body. In the trachea, you can see the breathing here, how the child is breathing. See the breathing pattern.
The volume is slightly reduced.
Now you can see.
You can slightly reduce the volume. Yeah.
You can see the anesthetist is now anesthetizing. You can see the saturation was 42 here. And once the foreign body was removed, you can see the saturation is 100. So immediately the child will improve the technique. And you see this is a 9 years old child. You can see the child is having severe distress. You see the patient.
Your voice is not audible.
You can see that. See, gasping for breath. We took the patient immediately and we have removed the foreign body. So whenever we suspect a foreign body bronchus, what we have to do? We need to take a thorough history, ask for the choking episode, and do good clinical examination. Auscultate the chest. So as ENT surgeons, I think this is the only time probably I use a stethoscope, auscultate the chest for a decreased breath sounds or absent breath sounds, and get an X-ray done. In majority of the patients, we see an obstructive emphysema. We see wide variety of presentations, but I'll just be showing in my X-rays. And CT scan is not done routinely. So CT scan is reserved. See, when the patient comes with a history of choking episode, and there is an auscultation, there is decreased breath sounds, and X-ray, there is some finding is there. I don't go for CT scan. Straight away, I take the patient to the operation room and remove the foreign body. But the patient presents with persistent respiratory infections and cough, breathlessness. When I suspect a foreign body in the tracheobronchial tree without history of choking, then that is the situation. I go for a CT scan. So CT scan is difficult because the child will have breathing, so we cannot get a clear film. So that is the reason we don't go for CT scan in all the patients. So X-ray is the one which is commonly done in my practice, and CT scan for this reason, because the respiratory motion is there, so which results in poor images. So we don't. So majority of the times we depend on history, clinical findings, and an X-ray. So these are the variety of findings that we get in the X-ray, and you can see a normal X-ray does not rule out a foreign body. in any child, because for the child to develop radiological findings takes quite some time. Now imagine now the child has swallowed or aspirated something. We get an X-ray. We don't get any finding in that. It takes some time for the X-ray to for the child to develop respiratory symptoms and then findings. And yeah, see, this is the patient who has a obstructive emphysema here on the right side, and you can see this is the collapse of the lung on the left side, and this is a pneumonatic changes are there. This is a radiopaque foreign body. So the wide variety of findings of the child will be there. So these are the foreign bodies which has got a radiopaque foreign body. This is a fractured tracheostomy tube. This is a pen cap, metallic one, and this is a stone. So these things leaves no doubt as to we have to go for a bronchoscopy and remove the foreign body. See, this is a scenario. See, when the child has a bilateral emphysema, just like this. See, this both the lungs are, a lot of air is there entrapped there. So this child has a bilateral foreign body. So when the foreign body is on one side, you can compare with the other side. But when the child has bilateral foreign body, wherein there is reduced airway both the side, it would be difficult for us to diagnose, and that means we have to be beware of that. That's what we said, that beware of the silent chest, that is a bilateral foreign body is there. So friends, once we know that we are going to do a bronchoscopy, we have diagnosed that the patient requires there is a foreign body, suspected foreign body, then we need to do bronchoscopy. So then how do we prepare? This is a very important thing. So you check all your instruments and call anesthetist who is experienced man in bronchoscopy, and call theater staff who are regular to you, and preferably you do bronchoscopy in one hospital, because if you keep on moving from one place to one place, you may forget one instrument at one point of time. You'll be handicapped. So preferably if you do at one hospital removal of foreign body, you will have all the foreign bodies at all the instrument at your disposal, and you are familiar with the surrounding, and your OT staff whoever are assisting are familiar with whatever you do, and so that will have a favorable outcome than doing different places. And last but not the least, see, we have to counsel the parents. See, what I do is that I counsel the patient once preoperatively before the anesthetist arises as to what is the danger of the procedure, what is the danger if we don't do on time, and what are the complications if you do. So we tell our experience that how many patients that we have done, what was the outcome, what are the realistic, we don't give the false promises, and we tell what is the fact. And then once the anesthetist arrives, we both, anesthetist and myself, sit with the patient parents, and however illiterate they are, will try to explain in their own language. So that is very important to do. That's the last one. So if you prepare 2 hours for your bronchoscopy to remove foreign body, it takes just 2 minutes for you to remove the foreign body. If you take 2 minutes to prepare, it will take 2 hours to remove the foreign body. Mind you, this is a very important saying. So these are the instruments for the bronchoscopy. See, the most important we must have all the ventilating bronchoscope of Storz make. All the sizes you must have. This is a reflecting prism, and this is a optical forceps, and variety of Storz forceps, and this is a basket, and these are the non-ventilating bronchoscope or Indian make, and variety of forceps you must have. So this is a word about optical forceps. This is optical forceps wherein the endoscope will sit here up to here, and the prongs are this, so that the foreign body can be removed easily by using optical forceps. And I will be telling the advantages of telescope and other things in the subsequent slides. So what anesthesia the anesthetist will give is a big lecture again. I don't want to go into the details of anesthesia, but there are 2 techniques that we use. The number one is jet ventilation. When you use conventional Indian bronchoscopes, so jet ventilation, you can remove foreign bodies. Not that everybody should have a ventilating bronchoscopy. Ventilating bronchoscopes are expensive, but if we have, it's very safe, and it is for the patient, and for the surgeon it is very good, ventilating bronchoscopy, but they're expensive. But at the same time, you should not feel handicapped just with having a Indian instruments with jet ventilation. We have removed many foreign bodies. Not that we can't do it, but I think both, if you have both, that is very good, because at one point of time you may not be able to remove the foreign body. The procedure may have to be prolonged. In those scenarios, ventilating bronchoscopy is very good, so that you can do your procedure for a quite long time. So the advantages of telescope. See, what are the advantages of telescope is that, see what I do in my practice, see, you can see the foreign body clearly, plan what forceps you are to use, and once you remove the foreign body, you can even look for a second one. And if you incorporate endoscope along with the optical forceps, you can remove the foreign body with the minimum damage to the mucosa. But the disadvantages of telescopic bronchoscopy is that optical forceps is a quite big one, which cannot be removed, which cannot be used below 2 years because of the small size of airway. And another disadvantage is that it takes more time for you to use the telescopic bronchoscopy, because it needs to be connected, it has to be dismantled, and you should have intelligent assistant to give you on time. It takes more time. But in conventional, this one, you can remove the foreign body very in the very minimal time. So that's a disadvantage, because you cannot use the telescopic bronchoscopy in a real dire emergency. But in below 2 years of age, we can use telescope only to visualize the foreign body. So that's the advantage. So if you look at what is the tracheobronchial, we all know that the foreign bodies are common on the right side in older children and adults. But below 2 years, the angulation is one and the same. You can see in this video, this is a 18 months child. You can see there is no angulation between right and left. So that means to say that the foreign bodies are common on both the sides. You can see very clearly there is no angulation. It is only the angulation comes only above 2 years of age. See, what I do in my practice is that the anesthetist will show me the card. I use a nasal endoscope, 4 mm scope attached to the camera. I'll pass into the trachea and then on to the, see, you can see in this patient, the Sitafal seed is there on the left side. I noted the position and I noted what forceps has to be used and what is the forceps space available. So that's the advantage of using a telescope. The telescope that I am using right now in this patient is the nasal endoscope, which will reach up to here. You can see the pen cap stuck here, so that I know what forceps to be used. So I'm using a not bronchoscopic long telescope, but I'm using the telescope that is used for the nasal surgery. That is 4 mm telescope. So now I'm just seeing this patient has a peanut in the trachea, that is in the coronal plane, you can see. And now if I bring this foreign body in the same plane, it will get sheared and it cuts at the level of the glottis, because the glottis is like this. Glottis is not like this. So I need to do version of the foreign. That means I need to change the position of my foreign body into the vertical plane so that it can be removed easily. That version has to be done. So many of the times you need to change the position of the foreign body according to the, see now I change the position into a sagittal plane. So now I hold the foreign body. See, if you hold the foreign body more than 50%, then it comes easily. So now at the level of the glottis, you need to tilt the forceps like this so that there is more space in the posteriorly, so the foreign body comes. So now once we remove the foreign body, then you check the tracheobronchial tree again with the telescope only for any second foreign body or residual foreign body. See, if you hold the foreign body more than 50% only, the entire foreign body you can remove in one piece. If you hold 25% of the foreign body with your forceps, only 50% of the foreign body you can bring it out, especially if it is a vegetable one. So that is called as equator of the foreign body. Equator means you have to hold in the center of the foreign body so that you can extract the foreign body as a single piece. See, now this is a patient with a right main bronchus peanut, I know peanut is a common foreign body in our Indian scenario. See, now I am just inserting the telescope into the forceps. So once it is ready, then now I am, see, now I inserted into the sheath, and now I am removing the foreign body with the telescopic forceps. So telescopic forceps has to be always used with the sheath in the tracheobronchial tree. Without bronchoscope in the so never use a telescope. That's a dictum. See, now once we remove this is the foreign body, so I'm using a telescopic forceps. So once we remove the foreign body, small bit of pieces are left in the segmental level. You can see, which cannot be removed by the forceps. So all these things will come out in the post-operative period on coughing. Only thing is, we need to make a note of it in our OT notes, and we need to explain the same, that small segment pieces are left in the tracheobronchial tree, which are likely to come out on coughing. We have to explain to the parents. If it is a bigger one, it may require a second sitting also. We have to tell the parents about what has happened. And there is we also need to know that when we have to avoid doing bronchoscopy. This is a very important thing. There will be some medical conditions wherein we may have to do bronchoscopy. That's a pediatrician may suspect a foreign body and call you to do, but we should not do bronchoscopy when a child is severely breathless and no cough. Severely breathless with high fever. Breathlessness started after an attack of cold or fever, and there is no history of aspiration. So all this puts, and it mimics foreign body, but it is a medical condition. So you can see a child like this. You can see this child. Yeah, see, when the patient has medical condition, fever is there, no cough, a toxic child without any history of, this video somehow is not playing. Yeah, this child is very toxic. So this kind of scenario, we should not do bronchoscopy. So when a patient comes with for the bronchoscopy, we ask the parents to have another duplicate foreign body. Suppose if they've swallowed some kind of a plastic one, so ask them to get the same one, so that how it is inside. So with what forceps can be used, all those things can be studied. And always think about the previous cases, how you have studied, how you are removed, and all the details you collect yourself, and get the scan or X-ray in 2 or 3 plane, so that we can see how the foreign body is lodged in the. And always when you have doubt, ask the seniors as to what to do. So the procedure is, is under GA. I'll be just showing. See, how we do. The patient is. Videos are somehow not playing. And now you can see the anesthetist will show the cards like this. Show the cards, and then I put my bronchoscope into the tracheobronchial tree, and now so you can see the light. This is how you must introduce the your scope. Then next, again, he'll show the cards. Oh, what is happening? This. Show the cards like this, and the 10-year-old child, I can see when I want to see on the right side, when I want to use the left side, I turn the head to the right side so that the trachea and the bronchus are in the same plane. And this patient had a plastic results, all 3 parts. Then this child you can see like that. I am using conventional scope to the breath ventilation and remove the foreign body. All at once. Forceps, foreign body, as well as the bronchoscope because the size of the foreign body is bigger than the telescope. So now you can see this patient has come in a very, very respiratory distress. You can see the foreign body got stuck in the level of the glottis. You can see here, and the anesthetist is just showing the cards to me. I removed without even passing the bronchoscope, because if I pass the bronchoscope inside, the foreign body will go into the trachea. So without using the scope, for the first time I removed the foreign body as a whole piece from the just in between the glottis, because in this situation you can neither intubate nor you can pass it. See, again, this patient had a blouse hook stuck in the glottis. So this patient we cannot intubate nor ventilate. See, this is stuck, the anterior part, the blouse will have like this. Then the hook, if this hook got stuck in the anterior commissure like this, I am trying to remove without scope. The anesthetist is showing the cards. One hand I am holding the endoscope, a camera, and my right hand I am using the forceps. But you see how difficult it is to remove once it gets stuck. So I stopped recording, and then I removed the telescope, and then I removed the foreign body. So these situations you see. See, this is a patient who had a severe respiratory distress, wherein the big piece of plastic was stuck in the subglottis like this, and the child was having very, very severe respiratory distress. So now if I put my bronchoscope into the trachea, it may go down. So I am started trying to do like this, because it is just under the vocal cords, and you can see the position of the foreign body is not favorable to me to just remove it. We have to change the position of the foreign body into the, see, it is like this in the coronal plane. So now I have to I made it, see, it is difficult to remove now because of the size of the foreign body. I am unable to do that. So then I asked the anesthetist to ventilate for a second, and now I took the ventilating bronchoscope. Now you can see this is the ventilating bronchoscope with the prism here attached, and now my bronchoscope will be like a endotracheal tube to the anesthetist. Now is ventilating through this port. Now I am removing the foreign body through, I am not using any telescopic forceps. I am holding the foreign body with the toothed forceps. This is the patient, the forceps will have a crocodile forceps type. Now I change the, you can see my movement, I change the version, and then I remove the foreign body. This is quite a big one, you can see, it's quite a big one, and the child became all right. See, now this is a 3 months old child. We had a foreign body nail in the tracheobronchial tree. Here you can see, just 3 months child. You can see this. We have removed the foreign body with the conventional instruments. You can see this was done 12 years ago. Yeah. Now this child is 13 years now. Yeah. See, this is a very tricky situation where the metallic foreign body of this size got stuck into the right main bronchus. So this is a metal one and slips. Your forceps will slip with the when you hold the forceps, it will get slipped. So it is very tricky situation. You need to be very, very fast in this situation. Yeah, this is again a interesting foreign body where you can see a bunch of stapler pins got stuck in the left main bronchus. We need to remove this bunch as a whole. If you don't hold this foreign body as a single unit, then you may have to remove by one. Then the one foreign body will become multiple. So this is the telescopic forceps, the ventilating bronchoscopy. You can use for a long time. You can see. Again, I'll show you. This is a first I see the nasal endoscope. I passed into the tracheobronchial tree. Now what I am using is a 4 mm nasal endoscope, just to visualize where the foreign body is. So don't jump at this point with the small forceps and try to hold. Now I am using a ventilating bronchoscope. You can see anesthetist is ventilating here, and now I am removing the forceps along with the secant foreign body. So that is the beauty of ventilating bronchoscope. See, now this is the foreign body buried in the granulations in the left lower lobe. Very long-standing foreign body. See, these are the granulations. You can say I just use a telescope to visualize where the foreign body was, and I removed. This was a very challenging one because see, these are the granulations. The foreign body was there for about 2 months in the tracheobronchial tree. So in this scenario, it will be very difficult for you to negotiate the through bleeding. So this is a very, very interesting case. I put my nasal endoscope inside. You can see, I see a foreign body here. I removed the foreign body, but the still saturations were not improved. So you can see this mucus was showing. You can see this foreign body was here. And again, I put my telescope onto the left side. You can see this leech of mucus like this. There was, to my surprise, there was another foreign body of different nature. This was a peanut on the right side. On the left side, you can see there is a dal seed was there. Two different types of foreign body in a single patient. So always, once you remove a foreign body, always look for a second one. There may be a small residual foreign body. Altogether, there may be a new foreign body also. So I removed this foreign body too. Yeah, this is a metallic foreign body in a small child. Once the foreign body was removed, I noticed a very, very rare anomaly in the trachea that is called as a pig bronchus. That's called as a, you can see here, this is a tracheal bronchus. There are two, this is the carina. You can see this is the carina. This is the left main bronchus, this is the right main bronchus. And this is what is called as a tracheal bronchus or a pig bronchus. Is a very rare anomaly that I have encountered first time in my practice. This is a tracheal bronchus. Yeah, you can see 3 bronchus here. This is a tracheal bronchus. This is one of the conditions where this child was referred to me, my pediatrician, for a suspected foreign body in an emergency. So there was no history of choking, but the child was severely breathless. So once I put my telescope into the trachea, I have seen the trachea was compressed from posteriorly. You can see here, this trachea is compressed posteriorly, wherein I cannot pass my nasal endoscope beyond this point. So I suspect something in the mediastinum, and I abandoned the procedure. And post-operatively, we got a scan done, and we see a mediastinal tumor like this. And this is one of the most difficult one in my practice, that you can see that the child has a foreign body with a lot of secretions in the trachea, and the child has to be intubated in the operation room before I could remove the foreign body, because the saturations were falling. The moment I keep the endoscope into the tracheobronchial tree, the saturations were falling like this. You can see, so the anesthetist has removed my tube, and the patient was re-anesthetized, and endotracheal tube was kept, and the patient was saturated, and the foreign body was removed subsequently. The moment I removed the foreign body, you can see the saturation has come to the 100. So that is so this patient was done, this surgery was done around, you can see in 2015 we have done. So sometimes we cannot remove the foreign bodies. They get impacted. So in those situations, what we can do? So this patient is one of that kind. The foreign body was first to start with was here, and they went to somebody for the foreign body removal. They attempted removal, and they could not remove, and the foreign body was dislodged and got it into the right main bronchus, and subsequently they did tracheostomy. I don't know why, and the patient was referred. So I tried to remove the foreign body, but this was like this metallic foreign body with a, so this will be present in cigarette lighter. So I could not remove the foreign body. So I referred the patient to a place where many ENT surgeons do. It's a government setup in Hyderabad. So they tried on several occasions, 4 to 5 times they tried, but they could not remove foreign body. So this was impacted, and ultimately they have referred the patient to thoracic surgeon, and the foreign body was removed at thoracotomy. So this can happen. So foreign bodies are also common, not common in adults, but still we see from time to time. So this is, I removed about 5 to 10 foreign bodies in adults. So this was an adult, and this is a needle. You can see this needle was piercing the mediastinum like this. The hypodermic needle I removed from the trachea of a child. And this is one of the interesting foreign bodies. You can see in the glottis, the dentures were stuck in the glottis over a period of 15 days. He has come to the voice change and severe breathlessness. You can see this is the dentures. So at the anesthesia, so we could not intubate nor ventilate the patient. The anesthetist is showing me the cards like this. So I removed the foreign body with a big forceps like this. This was a dentures in the glottis. And this is an interesting foreign body. This is a big chunk of betel nut got stuck in the trachea. So we have tried to remove the foreign body through the glottis, which was not possible. And this is the only one instance in my entire practice that I had to do tracheostomy for this patient to remove the foreign body, because the size of the foreign body was bigger than the glottis. We could not remove it as a whole. So in the midnight, about 11 o'clock, in the peak summer, I cannot forget this patient, because we have removed this that hour at about 11 o'clock in the night. The entire city was in the pitch dark. There was no electricity. So we removed this foreign body with the tracheostomy. That time, you can see that I did a tracheostomy and I removed the foreign body through the tracheostomy. Post-operative, we just closed the tracheostoma 2 days following foreign body removal. Then the patient is doing well. So now I just want to conclude that foreign body removal from tracheobronchial tree is an art, and we need to learn the art and understand the science behind it, and we need to anticipate the difficulties, and we need to be ready to manage them from time to time. Mind you, you should not do bronchoscopy for a non-emergency. Bronchoscopy is emergency, we all know that. But when the patient has a foreign body for the past 1 month, and the patient has come to you at about 7 o'clock in the night, the patient is not having too much of respiratory distress, it's a good idea to give good antibiotic and then give proper chest physio, and then you give astaline and other things. Then you take do bronchoscopy in the next morning. Unless it's an emergency, don't do bronchoscopy in the night. Suppose if the child is having severe febrile without any cough, please think twice to do before you do bronchoscopy, because think about medical conditions. So that's very important. So for a medical condition like acute laryngotracheobronchitis, ALTB, if you put bronchoscope into the tracheobronchial trach, a small child, then the post-operative period will be terrific, and we may lose the child because of the excessive edema that we create because of our instrumentation. See, whenever the foreign body is stuck, there are very small, tiny foreign bodies which are stuck at a very low level where there is no forceps space. Just abandon the procedure, and many of the times the foreign body comes out on its own on coughing. Or otherwise, just make a note of it in the operation notes and explain to the parents, so that we can do at a later part of time. Or there's another one scenario that you have removed half the foreign body and another half is got stuck without any forceps. Be honest, come out, then don't try for too many times. Don't do bronchoscopy for 30 minutes, 40 minutes, 50 minutes. If you can't remove foreign body in 10 minutes time, I don't think even if you take 1 more hour also will remove. Just abandon the procedure. Either you send the patient to the proper place where it is done, or you do bronchoscopy maybe after a week by giving good antibiotics. But please be honest. Explain to the parents that there is a foreign body which could not be removed. Everybody will accept. Everybody, we are not heroes after all. So we have to be very honest to the parents and then tell them that there is a small piece left, we can remove it. But only thing is, when you redo bronchoscopy, do free of cost. Or if you are in the private practice, what I do free of cost if I do for the second time. So if you can't remove the foreign body, that's what I said. Don't do repeatedly. Don't don't do any harm to the patient. Okay, you refer the patient to the proper place. So if you have a careful planning with good instruments, good pre-operative preparation, and if you're experienced, definitely you'll have a better outcome. So now we can train all our postgraduates, young ENT surgeons, with so many other things like tonsillectomy, ear surgery, and so many things. But when it comes to tracheobronchial foreign body, always a senior most person in the department will do the bronchoscopy. So then how do the youngsters get training? It's $1 million question. So everybody wants to do, but it is very difficult to learn. So now we have, because of those questions, whatever we had in mind, I conducted a hands-on course for bronchoscopy in 2011. So we did with the cadaveric, mannequins, and workshop. These are the three things that how we get trained with the bronchoscope. See, now we have lot of mannequin courses for flexible fiber optic bronchoscopy to learn the art of anatomy, to learn the art of technique of bronchoscopy, and to learn the anatomy. But rigid bronchoscopy, to my knowledge, there are no hands-on courses so far. So we can only learn these things on mannequins. So how should we learn? Let's see. See what I did. I made a rubber tube mannequin like this. I took a box made like this, and I put a Mellicott scatter into the box and fixed like this, and I pass telescope and bronchoscope like this. I leave some foreign bodies inside, and I practice like this. So if you practice like this, see what will happen is that, just look at this video. This is a rubber tube mannequin wherein I put a foreign body into the tube and practice like this. What will happen if I practice like this? My hand and mind coordination will be there, and I learn depth perception, and I will learn the art of passing the instruments. So all these psychomotor skills has to be acquired on the mannequin. See, how do we learn endoscopic sinus surgery? We learn endoscopic sinus surgery by doing cadaveric dissections. We learn endoscopic by doing diagnostic nasal endoscopies. But tracheobronchial foreign bodies, we cannot learn on the cadavers because we cannot go to a mortuary. So now, how do we learn these psychomotor skills is to do a rubber tube mannequin like this, which I designed. Actually, this was described by Jackson and Jackson in his textbook, but I just little modified that. So next thing is, you have a sheep lung mannequin like this. You get on any Sunday morning, you go to any slaughterhouse, you get 2 lungs and a trachea. You tell them, show like this you want, and these are larynx. Usually they cut with the head, so they cut with the head. So you take this larynx separately and suture it like this, so that you will have a feel of passing your bronchoscope through the glottis. How you do it? You see that how it is done. So this is a sheep lung mannequin which is fixed onto the stand like this, and now I pass my telescope into the trachea. Now I will see the left and right main bronchus. The trachea is little longer than the human, and practice the removal of foreign body in the sheep lung mannequin like this. Again, you learn the psychomotor skills, how to pass the tracheoscope and remove the foreign body like this. So you learn these techniques by the mannequin. So why do we require mannequin? So now number one is the learn hand and eye coordination, and you learn the psychomotor skills and learn the depth perception at what the level the foreign body is there, how to hold it, what is the forceps space, and all these things you learn. And also you learn the art of handling the instrument. See, if you know how to handle the instruments in ENT as such, not only bronchoscopy, tonsillectomy, or endoscopic sinus surgery, ear surgery. If you know how to learn how to hold the burr, and you have a very good burr control, then you have half done. So like that, you must learn the art of handling the instrument. You should not be clumsy. And when you do bronchoscopy, there will be hardly any time is there for you to practice on the patient when the patient is anesthetized and the saturations are dropping. All those teething problems you have to have the art of handling the instrument, the mannequins, then all those skills you pass on to the operation room for a safer foreign body removal. I thank you very much for your kind attention, and I thank the CIPODEM people for conducting this webinar and giving me this opportunity. If there are any questions, I can take them. Hello?
Yes, sir. Yes.
Is it okay?
Yeah, can you hear me, sir?
Yeah, I can hear you. I have finished my presentation. I think I'm on my time.
Yeah, you're right, sir. So there were a
Yeah.
lot of questions. I mean, I would like to confine in a few numbers because some of the questions are very similar. So I will post one by one question to you, sir.
Sir, how many
Uh,
questions are there?
there were around 90 questions, sir.
90?
90, yeah.
Oh
So
my God.
I
How
would
many
like to,
viewers are there
no,
now?
so that we need to find out, sir, from the technical part that I will
Yeah.
get back to you.
Yeah.
And regarding these questions, because I mean, some of these questions are very similar. So let me put the questions to you directly.
Yeah.
One is which is the most difficult foreign body in the bronchial passages to be retrieved through bronchoscope? The question is from Dr. Nirdosh Safaya from
Yeah.
Noida.
You know, which is a difficult foreign body to me or to the patient?
No, which is the most difficult foreign body in the bronchial passages to be retrieved through bronchoscope?
Oh, see, any foreign body, any sharp foreign body, which is there in the tracheobronchial tree, is a difficult one for to remove because it may tear the walls. Number one. Number two, a vegetable foreign body of long standing is a difficult foreign body because it will become into pieces once the whole. Number three, a foreign body is most difficult when it is swollen. See, when it goes inside, it is a smaller one. The vegetable one, as you see, the betel nut will become swollen. It's a difficult foreign body. For a patient, which is difficult, is the betel nut. That is the betel nut, which is commercially there in the pockets like crane, other things, which contains a lot of chemicals. That is very dangerous foreign body for the patient because it produces intense bronchial congestion and a lot of reaction will be there. So there is a difficult one. I think I've answered your question. Next, please.
Dr. Pasupati from Vaitisuran Koil is asking you, what are the
Yeah.
most common foreign bodies you come across in today's practice in children?
The most common foreign body in Indian scenario is the peanut. Peanut is the commonest foreign body in my practice.
Yeah, Dr. Satya Kumar from Nizamabad
Yeah.
is asking, which are the, can you brief about the radio opaque foreign bodies?
Yeah, radio opaque foreign bodies are, see, these are the radio opaque. Can you see my screen?
Yes,
Yeah,
sir,
this
yes.
is the radio opaque foreign body. Fractured tracheostomy tube is a bigger one. This is the radio opaque foreign body. These are metallic ones are radio opaque actually. So this is the radio opaque foreign body. See, the foreign body radio opaque because of the metallic nature, and it is not very difficult to remove these foreign bodies because they don't break into pieces. So for that matter, vegetable foreign bodies are difficult for us. Yeah.
Yeah, Dr. VB Singh from Allahabad
Yeah.
is asking, please tell some guide on periphery area to prevent complication in child before refer to IR setup.
Yeah. See,
Guide on periphery. Yeah.
Yeah, see, whenever you suspect a tracheobronchial foreign body in a child, number one, if the patient is having severe breathlessness and saturation is falling, that means the foreign body is there in the trachea or in the subglottic region, which has to be removed at the earliest possible time. So you have to refer to a proper place where it is being done. So before you refer the patient, so just nebulize the patient, give steroid injection, give a very good antibiotic, and keep the patient on oxygenation and send the patient to a proper place as soon as possible. That's all you can do. Yeah. Next.
Dr. Jairam Gowda from Bangalore.
Sir.
The question is role of correct thyroidectomy in airway foreign bodies.
Yeah, it's a very good question. Suppose if the foreign body is stuck at the level of the glottis, very big piece of foreign body which is stuck at the glottis, in those scenarios where neither you can intubate nor ventilate. This is a difficult scenario. In this scenario, you can do what is called as cricothyrotomy. Yeah, this is a only indication. But if the patient has time to reach the hospital, and there is always time to remove the foreign body. So this cricothyrotomy is very, very rarely required. At least I have not done any cricothyrotomy in my practice. Yeah, next please.
Yeah. Dr. Atira Thomas from Mumbai. What is forceps gap, which you referred?
Yeah, that's an excellent question, madam. So the forceps space is the one. I'll just show you. Yeah. Yeah, you have a careful look at this video. See the space that is there between the foreign body and the bronchial wall is the forceps space. See now you can see here in this situation. Yeah, you can see this foreign body here. So the forceps space is between the foreign body as the bronchial wall. Whatever space is there is called as forceps space. I think I have answered your question. Thank you. Next.
Yeah. There is an interesting question from Hyderabad from Dr. Sanjeet Kumar. How to manage foreign bodies in the background of COVID pandemic?
Oh, yeah. See, thing is, sir, one thing. Yesterday, I received a phone call from a place where it is 160 kilometers from me, that there is a case of tracheobronchial foreign body, which can be referred to you so that I can remove it here, because there is no one to remove in that place. But the problem is that, number one, they can't reach here. So even if they reach here, so if I have to take up the patient for tracheobronchial foreign body retrieval of the foreign body, I need to be informed. I need to be careful that the patient is COVID negative, number one. If it is negative, even the child may be in the window period. So then I have to take almost all the universal precautions, other PPEs and other things. I need to remove the foreign body. The management is one and the same, but only thing is we need to protect ourselves. It is not the problem to the patient, but to the surgeon. They have to do it. There is no other go. We can't postpone a foreign body bronchus for the reason of COVID. Next, please.
Yeah, next question. I think you must be your good friend, Dr. Madhusudana Reddy from Kurnool. So what will happen, Dr. Madhusudana Reddy?
Oh, hi.
Sir, what will happen if unexpectedly child would have given multiple nebulizations in thought of asthma?
Yeah.
Is the nebulization force leads to push the foreign body deeper? Is it true? Kindly explain.
Yeah, it's a very good question. But the thing is, the foreign body, if it is a quite small one, it keeps changing the place. Like suppose if the foreign body is a smaller one, which is not stuck at that level. Suppose if the foreign body gets, see, so this foreign body, whatever is there, you can see this foreign body will never move from that place. It is because it is snugly fitting in this area. You can see this. Yeah, there's a pen cap. You can see here. It is snugly fitting. It will not move at all. But whereas this foreign body, which is loosely present here, it may wander here and there. So by giving nebulization, your foreign body will not move. By forcible coughing, it will definitely move from one place to another. So today, if it is there in the right side, tomorrow it will go on to the left side, and the child will have changing signs on the X-ray if you take too many times X-ray. So it leads, the changing signs on the X-ray is an indication to for bronchoscopy, because there may be a wandering foreign body. Yeah, by giving nebulization, usually the position of the foreign body will not change unless the child has very severe, profound cough.
Yeah, there are multiple questions from one doctor by name Dr. K.S. Srikanta Rao from Bangalore.
What's his name, sir?
Dr. Srikanta Rao from Bangalore.
Yeah.
What is the youngest age for bronchoscopy? First question.
There is no youngest age, sir. It is not a surgery, no. If the patient of one month child has a foreign body, we have to remove. 3 months child foreign body, we have to remove. There is no age gap here because it's tonsillectomy. Okay, we can operate after 3 years or something like that. But in a foreign body, age is not a matter. But only thing is you need to have the right instrument for the right patient. That means you must have all size. That is what I said in my presentation. Whenever you have to do bronchoscopy in a child, you must have not only 4 or 5 bronchoscope, you must have variety from number 3 to number 8. All the sizes you must have. Yeah.
Yeah. Same doctor, Dr. Srikanta Rao.
Yeah.
Foreign body is in the respiratory tract looks like an emergency. Generally, how good is the hospital preparedness, team availability in talk?
No. I didn't get the question.
Yeah, foreign body in the respiratory tract looks like it's an emergency. Generally, how good in the hospital purpose? How good is the hospital preparedness, team availability in taluk or district hospital? Who will do the bronchoscopy, ENT or pulmonologist? Chronic foreign bodies are misdiagnosed many times. Do you agree with me?
Yes, correct. See, thing is, in majority of the places, ENT surgeons are doing foreign body bronchus. In some centers, pediatric surgeons are doing. In some centers, cardiothoracic surgeons are doing. In some center, I know one place where a pediatrician has a flexible bronchoscope. He is removing the foreign bodies. But ENT surgeons are the more people who are well versed with scopies and rigid bronchus. See, foreign body bronchus is removed by a rigid bronchoscopy, not with a flexible bronchoscopy. So most of the times, it is the ENT surgeon who does the bronchoscopy. Anybody, for that matter, whoever can do it, then this subject is overlapping between so many people. So whoever is competent enough, they can do it. Yeah.
Yeah, Dr. Dharmesh Yadav Rao from Risod. What are the measures done by the parents?
So
what are the measures or activities done by the parents to remove or maintain the child stable? Or do's and don'ts?
After they aspirate or
before and after. Before they bring the child and after.
No, I didn't get the question actually.
So what are the do's and don'ts by the parents once they come to know that there is a foreign body? I'm rephrasing.
The do's is immediately they should come to the medical attention. They should go to a pediatrician or ENT surgeon, whoever is available there, and they will do this one. Sir, don't neglect it. That's all. They have to seek the medical advice as early as possible so that it can be retrieved very early at the early. That's all.
Dr. Dharmesh, another question: if oxygen is available in ambulance, can it be given?
Yeah, oxygen can be given. It's a very good So the patient with the tracheal foreign body gasping for breath, if you give oxygen, you can buy time. Yeah, oxygen. See, that's what I'm telling. See, when you know that the child has a foreign body and you cannot remove it, you are transferring the child to somewhere else. So what all things you need to do? Number one, oxygenation. Number two, give us hydrocortisone hemisuccinate injection, not betnosol or something like that. Hydrocortisone. Then good nebulization and antibiotic and just physio. That's all. That is the thing you have to give. Oxygen is very important. Yeah. Next.
Yeah. What should be the position the child should rush to the hospital?
Rest in the?
When the child is brought to the hospital, on what position should be brought?
The child will acquire its own position according to their, see, this is the position the child will be more comfortable with the foreign body. See, the child will take its own comfortable position. We need not keep the child in a comfortable position. The child itself will know in which position they can breathe well. Yeah.
Yeah, Dr. Purushottam Rao from Tenali.
Yeah.
Any experience of with case of fatality of in this type of cases?
Sir, see. That's an excellent question. See, this to date we have managed around 1,450 and odd cases over a period of 20 years of my practice. So far, I had only one fatality. Yeah. So that fatality has happened because this child had a severe respiratory distress without a history of foreign body. The child has come at about 10 o'clock midnight, at 10 o'clock in the night. And I was not ready to do foreign bronchoscopy for that child because I was not in favor of suspected case. But still, the pediatrician said, anyway, the patient is going to die or patient is very, very sick. So why don't you at least have a trial of it's probably a medical condition. So he said, why do you take a chance? So I just put the bronchoscope and see But anyway, child did not die on the same day, but the child died the next day. I don't think that is a surgical death. That is due to some medical condition. The child has died. So to date, no mortality, at least in my place, in my hands.
Sir, any tips on anesthesia preparation? The question is from Dr. K. Sudhakar, Kadapa.
What they want to know, sir?
What type of anesthesia preparation we should do?
Yeah, that's a very good question. The 1 hour lecture, actually, this is the anesthesia for bronchoscopy. I am not the anesthetist to answer, but anyway, I try to answer a bit. See, in anesthesia, there are two kinds of anesthesia they give. One is the jet anesthesia with the jet ventilation, and second one is the, see, this is the jet ventilation and ventilating bronchoscopy. This is more safer than this. That's what I can tell you, because I am not the anesthetist. Our anesthetists are very competent here. I can do things. So I'm not. Usually, ventilating bronchoscopy is much safer, but you can manage with jet ventilation also. Yeah.
Dr. Manoj from Chennai.
Sir.
Can you brief on the position for bronchoscopy?
Sir?
Can you brief on the position of bronchoscopy?
Yeah, position is a neutral position. You see here, this patient, see, this is a neutral position. There is nothing, no extension, no sandbag, nothing is there below the shoulders or the head. You can see the neutral position. See, the neutral position. Yeah, next. Hello? Hello?
Yeah, the same question, almost the same question from Dr. Nageshwar Rao Vaizag.
Yeah.
Sir, please show the position of patient.
Position of? Hello? Hello?
Hear me, sir?
Yeah, what is the question?
Yeah, can I repeat the question? Yeah, I can hear you.
Yeah, what is the question, sir? I could not.
Please show the position of the patient. Yeah, kindly show the position of the patient and direction of introduction of scope.
Yeah, see, this is the how we introduce the scope. See, the patient is in a supine position with a neutral position without any extension. See, now the anesthetist using a Macintosh laryngoscope, he's showing me the cards. So I go into the, so once I go inside, when I want to go on the left side, I'll turn the head of the patient towards the right. When I go on the right side, I'll turn the patient to the left. Like that. So to make the trachea and the tracheal bulb will be in one line, because I'm using the rigid scope. So this is the position. See, I'm working here on the, see, I'm working on the right side. So my head of the patient is towards the left side. So that means the trachea and the bronchi are in one line, at least. You can see this.
Yeah, sir, your voice was not audible during the presentation of the.
So now, when I see, now the anesthetist will show the cards. Hello?
Yeah, kindly reduce the volume of the clipping, sir.
1 minute. Yeah, now you see, the anesthetist will show me the cards and I will introduce the scope into the trachea and then subsequently into the bronchus. So when I want to see on the left side, I will turn the head towards the right side. And when I want to work on right side, I turn the head towards the left side. You can see as well here, I am in the midline now, trachea. So now you can see here, I am looking into the right main bronchus. So my patient head is towards the left. So that means the trachea and the bronchus will be in the same line because we are using a rigid scope. See? And once I get the foreign body into the trachea, then I change the position of the head towards the center. See that? That's the position. We need to keep changing the position of the patient as and when you change the your scope into the right and left. Yeah. Anything more, sir?
Yeah. So few more questions, sir. What should be done? What is the management if the child has been brought with the fever and cough and breathlessness?
Yeah.
With the foreign body.
No. See, thing is, when the patient when we get a patient with a history of fever, cough, and breathlessness without history of choking? That is the question, no? Hello?
Yes, sir. When the question is from Dr. Praveen Kumar Imanshu from Samastipur. Yeah, eye fever, cough, and breathlessness. What is the care? What is care and management?
Yes, high fever, cough, breathlessness if the patient has, then I will not do bronchoscopy in that patient. Even if there is a history of choking is there, I will not do immediately bronchoscopy on that patient. So then I will investigate the patient. I will rather admit the patient, give a conservative treatment with antibiotics, then nebulizations and antipyretics, and the patient will be under the care of a pediatrician in the intensive care unit. Once the patient becomes afebrile, and in that situation, if the patient has radiological signs, or the child, mother or father gives history of choking, then I will do bronchoscopy. Then I will label that bronchoscopy as a check bronchoscopy, and I will do bronchoscopy once the child becomes afebrile.
Yeah. Dr. Dinesh Kumar from Jaipur.
Yeah.
Position of head while introducing bronchoscope in right and left bronchus.
Yeah, that's just now I answered the question. See, you see this video. When I am in the trachea, the head is like this. But when I see this, I am changing the head towards the right side when my scope is on the left side. Automatically, see this, you should keep changing with your movement like this. You must change. There will be nobody to change the head. You must change the position with your scope only. See? Yeah, like that you must keep on changing your position. Yeah, anything, sir?
Dr. Indrajit from Dharamshala.
Yeah.
I don't have a jet ventilation at my place. I have got a Karl Storz bronchoscope with port for ventilation. How should I proceed with the removal of foreign body?
No. He has a jet ventilation.
Yeah, I'll repeat the question.
Yeah.
I don't have a jet ventilation at my place.
Okay.
I have a Karl Storz bronchoscope with the port for ventilation. How should I proceed with the removal of foreign body?
Yeah, see, what you should do is that if you have ventilating bronchoscopy, you need not have a jet ventilation with you. It is better you get a jet ventilator. See, this jet ventilator, see, this has got a this is a jet ventilator. This will cost just 4,000 to 5,000 rupees. That's all. You will get in anesthetics company. Anesthetics. If you search in Google, this is called as Rouse double regulator jet ventilator. You will get in the anesthetics company. Number one. If you buy that, better to have both. If you don't have jet ventilator, what you can do is that you see this video. See. I'll just show you. Yeah. See, now this is the endoscope that has gone into the patient trachea, and now the lower part is connected to the ventilating port to the anesthetist. You can see this anesthetist is ventilating with this tube attached to the ventilating bronchoscope, and this glass shield will have 3 ports like this. When you want to remove the foreign body, you will slide this and then put your forceps into the trachea and remove the foreign body. When you are just viewing, you will slide this towards that side so that you will have only the viewing, so that the oxygen will not come out. So ventilating bronchoscopy is, this is what is the ventilating bronchoscopy. So you can connect your the bag to the this one. You can see the anesthetist is ventilating here through this, and you can remove. Your bronchoscope will be like a endotracheal tube. Yeah, but better to have both jet ventilation as well as ventilating bronchoscope. Next,
Dr. Farooq Agman from JNK.
Yeah.
Did you ever need to do tracheostomy while doing the procedure?
Sir, well, tracheostomy?
Yeah. Did you ever need to do tracheostomy while doing the procedure of foreign body removal?
Yeah, out of 4, I told you, out of 1450, this one, I did tracheostomy only in this patient. You can see here. So this is a patient. You can see I did a tracheostomy in this patient because the foreign body which was there for about 15 days in the trachea or right main bronchus was there. It was swollen to such a big one which I could not remove through the glottis. I made multiple attempts, but I could not remove. So what I did, I brought the foreign body till this part and I did a tracheostomy and removed the foreign body. This is the only one instance that I had to do tracheostomy in my practice. But once you do tracheostomy, you can close it within 2 days, no problem. Yeah, I did only once. But whenever it is required, please don't hesitate to do tracheostomy.
Yeah, Dr. Sachin Sharma from Jaipur. Any role of virtual bronchoscopy?
Yes, very good question. See, today we have reformatted images of the CT scan. They can give a virtual bronchoscopy image. See, whenever you order for a CT scan to the patient, suspected foreign body in a patient, you can ask your anesthetist to give a virtual bronchoscopy pictures. You can see the foreign body very clearly. See, that is what, yeah. See, this is the scenario. See, when the patient has persistent respiratory symptoms with no history of choking, but the child has cough, breathlessness, and it is being treated as asthma and pneumonia, then in this scenario, you get a scan done. Okay. Then you ask your radiologist to format these pictures, reformat these pictures, and the virtual bronchoscopy like film they can give you. You can see the foreign body in those situations. It's a good option. It's a very good question too. Yeah. Anything?
Yeah, Dr. Bharat Bhushan from Delhi said,
Yeah.
have you encountered difficulty in removing foreign body under jet ventilation? We had a case where where foreign body kept moving downwards because of jet ventilation.
Correct.
Please share your experience.
Yes, it's a very, very good question. And see, initially when I started my practice in, so I had only jet ventilation that time. So this is a big problem actually. See, that is why you ask your anesthetist to hyperventilate the child and they can hold on for a second or 2 or 3 seconds so that till you catch the foreign body. If they keep on pumping the oxygen with a high pressure, so keep on pumping, then the foreign body may move. So in between their jet, you have to catch the foreign body. So that in between, you can ask the anesthetist to hold on, keep a watch on the pulse oximeter, and then they can hold on for a 5 to 10 seconds, no problem. Oxygen will not fall so fast. You can remove the foreign body. But there is a chance that the foreign body keep on moving when you have a very big small foreign body with a high pressure. Yeah, there's a chance is there. Yeah.
Yeah, I think the next question is from your friend, Dr. Bashrat Nadeem from Bangalore.
Yeah.
He is appreciating you with about a wonderful lecture. And he's
Thank you,
asking,
Nadeem.
when have you required? Yeah, when have you required a CT scan for FB and TB3 evaluation in your experience?
No, I never had 3D evaluation. Eh?
No, FB and TB3 evaluation in your experience.
No,
I don't know whether it is. I mean, I just typed it wrongly. When can you share the experience of a CT scan requirements in your practice?
No, that is what. See, CT scan is done only in this scenario. See, when the patient comes with history of choking and these 3 signs, I will not do CT scan in my practice. If the patient has a suspicion and the patient has persistent cough, breathlessness for many days, then with the suspicion of foreign body, then I get a scan done, but not for all the patients. Yeah.
Yeah, Dr. Sampurna Ghosh, Hyderabad, many thanks. Dr. Ramasubramaniam of Chennai, marvelous presentation, no questions, and it is all self-explanatory. Dr. Rajiv Delhi, thanks to you. Dr. Ram Shankar from Tirunelveli is asking, kindly tell the size of ventilating bronchoscope.
Yeah,
according to, yeah.
See, the ventilating bronchoscopes are, these are the storage bronchoscopes. Yeah, these are available from size 3, 3.5, 4, 4.5, 5, 5.5, 6 like that. So all the sizes are available. So it depends on the patient's age that you need to select the right one. Yeah.
And Dr. Anil Kumar from Karnool asked the similar question which has been asked earlier. Excellent presentation. And in jet ventilation, won't the FB get impacted, which you have already answered? Dr. Mahesh Rati is from Pune is asking, which degree of scope is
0 degree. 0 degree telescope is used.
Okay, Dr. Vidya from Karwar, kindly explain how to introduce the instruments and position of the head and orientation of surgeon's hands with relation to patient. Explain with the video profile if it is possible. I mean, I think you have done it already.
How to?
Kindly explain how to introduce the instruments.
I have already shown,
the
no?
head. Yes, you have already shown.
Yeah.
Dr. Murali Krishna, nice videos, like it. And Dr. Ubav Mittal Bulancher, how to ventilate patient if we don't have ventilating bronchoscope? What tubes should we use for ventilation?
No, if you don't have
how to ventilate patient if we don't have ventilating bronchoscope?
No, if you don't
what
have
tubes to be used for
ventilation? No. If you don't have ventilating bronchoscope, you can use jet ventilation. No, you can use that and then remove the foreign body. Either of them you should have. Otherwise, you cannot do bronchoscopy.
Dr. Shamsher from Nellore.
Yeah. Hi,
what
Shamsher?
about doing it? Sir, what about doing HRCT chest before bronchoscopy?
Yeah, that's what I said many times. See, CT scan is not routinely done in my practice, at least. See, CT scan, number one, because it may not give good image because of the respiratory movements, number one. Number two, when you have a clear-cut history of choking and reduced breath sounds, then there is no need of CT scan. The CT scan is done only if there is no history of choking, nobody has witnessed the choking, and the child has persistent symptoms, then you need to do a HRCT scan. Otherwise, in an emergency, like the patient has a situation, see, the patient presents to you with this, see, if the child has a tracheal foreign body like this, there is no time for you to take even X-ray. So where comes the CT scan? That child is having severe breathlessness, we have to rush in and remove the foreign body. So in those scenarios, you don't do. We do only if the patient has persistent respiratory symptoms like this, then we do the CT scan. Otherwise, not in everyone.
Yeah, Dr. PVLN Murthy, Hyderabad.
Hi,
if
Murthy.
If you fail to remove FB, what is the next plan? What is the protocol? Counseling protocol. If you fail to remove the FB, what should be the counseling protocol?
Yeah.
Before and after remove FB. Yeah.
See, if you fail to remove the foreign body as a whole, this situation will happen in a vegetative foreign bodies, because the foreign body will be very fragile. Once you hold the foreign body, without force must hold. If you hold it, the one will become two. So you will not be able to remove the foreign body incomplete. Number two, if the foreign body, suppose if this is the foreign body, it is to be held at this point of time. At this point, 50% of the foreign body should be held by the forceps. That is called as the equator of the foreign body. Then the foreign body, you can remove it as a whole. Suppose if you cannot remove the foreign body, a piece is left in the tracheobronchial tray, and you made a repeated attempts, it doesn't come, then you abandon, and child will improve anyway with your half removal of the foreign body also. You tell the parents that this foreign body which was there has become into pieces, could not be removed because there is no forceps space or something like that, which has to be, the bronchoscopy has to be repeated at a later time, maybe after a week or 10 days. Give good antibiotic nebulization, the foreign body will change the position, and then you repeat the foreign body bronchoscopy and remove the foreign body. Otherwise, if we can't do that, then refer to a place where it can be done. Yeah, we have to be honest to the parents. If you leave the foreign body, and please don't tell them that we have removed everything and it's not done. Yeah.
Yeah, Dr. Jagmohan Reddy Kanjula from Nasuratpet.
Hi,
He's
Jagan.
appreciating, and
Yeah.
he's asking, can we get the recorded copy? Yes, of course, we will arrange for that. Sir. We will arrange for that.
Yeah.
And sir, Dr. Sampurna Ghosh from Hyderabad is saying that while you have presented the video on how to place bronchoscope, your voice was not audible. Can you explain again?
Yeah, definitely.
Because when you need to reduce the volume, sir, of the clipping.
Yeah, I'll just do it now. Yeah.
So reduce the volume. Yeah, you can explain.
See, the anesthetist will show the cards like this. You ask the anesthetist to hold the laryngoscope and be away from you. You will stand in the center of the table, and he will lift the epiglottis. See, normally they lift the they will lift the vallecula with the laryngoscope. But when you do bronchoscopy, you ask your anesthetist to lift the epiglottis also. Then once they lift the epiglottis, you have a clear view to the glottis. Then the bronchoscope lower end is beveled. It is not a sharp cut like this, a beveled one. So you keep the beveled one into the glottis and turn at once. So without trauma, your bronchoscope will enter into the larynx. See, I am doing like that. See, I cannot show you that, but yeah. Now I am into the trachea. This is how you must pass into the trachea. So once you pass this into the trachea, then what you need to do is, again, time and again, I told you many times, when you pass onto your left side, please turn your head of the patient towards the right side. When you want to pass your bronchoscope on right side, see how I am turning. My assistant is not turning. Myself, I am turning with the scope and forceps like this. So you must try to learn this act of doing. Otherwise, you will have tremendous problem, because the trachea, see, and see this position now. See, now my bronchoscope is in the right main bronchus. If I don't turn the head towards the left side, what will happen is that I may traumatize the party wall between the trachea and the carina. I will traumatize. If I turn like this, to at least to some extent, the trachea and right main bronchus are in the same line. That is what is the whole idea is about. Yeah. Okay. I think I have answered your question, Dr. Sampurna. Yeah, this is the foreign part. Yeah.
Yeah, Dr. Bhaskar Sharma from Gurdaspur. If child comes with respiratory distress and decreased breath sounds on one side, how to differentiate between FB impaction and effusion?
FB X-ray.
I'll repeat the question, sir. If child
I understood how to differentiate between foreign body and effusion. No?
Yes.
Right. Get X-ray done. If you still have a doubt, you take opinion from pediatrician, or you can get a scan done. There are a lot of ways of these things. Before you put bronchoscope, you have to be sure that what you are dealing with actually. Get a scan done. That's all.
Yeah, there were a lot of appreciation, especially from Dr. Murali Krishna from Nellore, Vishwas from Bangalore, Dr. Dinesh from Sivan, Dr. Srikant Rao from Bangalore, and there is a thing.
Thank you very much for your appreciation.
Yes.
Thank you, sir.
And I think still some more questions are there. I think we have now the questions has become 135 actually.
Sir, you can take last two questions, sir.
Yeah. Can you send the contact number of ventilating tube company from Dr. Arut Chelvan, Krishnagiri?
Ventilating
tube company. Contact number.
No, sir. This is actually, see, just I'll clarify his doubt. See, normal tube that we use for pediatric ventilation. See, this is a ventilating bronchoscope. This is a normal ventilating tube which is used by anesthetist, the pediatric circuit. Pediatric circuit is there. That can be attached. A plain tube is attached actually. It is not a special tubing actually. This is a normal tube. That's all. Yeah.
So they were asking for the contact number of the company who are selling.
No, that is that anesthetist will tell you. So there is a pediatric ventilating bronchoscope. There's a ventilation tube is there, no? That one.
Okay.
Yeah.
Sir, Dr. Ram Shankar from Tirunelveli. Any formula to calculate size of bronchoscope with respect to the age?
Yeah, this is all. See, this is all rough calculation. There's a lot of formulas are there for the endotracheal tube size. Even for the bronchoscope, also formulas are there. But see, by your experience, you will know which one to select. Actually, this comes by experience. See, below 2 years of below 1 year age, you select number 3, or below 14 3.5. About 2 years 4 number. So these all the experience that matters. Yeah.
Yeah. Dr. Mahesh from Delhi, sir, control of bleeding post removal of metallic foreign body.
Yeah. See, suppose if there is a lot of bleeding in the tracheobronchial tray with your this one, do gentle suction and just leave it. Don't do anything. See, if earlier days I used to put saline, wash it, then don't do that thing. If you ask your anesthetist to apply a saline, a 4% saline, a 4% xylocaine with adrenaline, you can just keep press for some time. So another point I want to make clear that once you remove the foreign body, just instill 3 to 4 drops of 4% xylocaine into the tracheobronchial tray, and if you have 10% xylocaine, please spray on the card so that the patient will not have a lot of cough because of our instrumentation in the post-operative period. And immediately upon removal of the foreign body, or immediately post-operatively, you nebulize the patient with salbutamol and other. In that nebulization, saline nebulization, please add 1 or 2 drops of 4% xylocaine so that the cough that is due to instrumentation will be reduced. Yeah.
Yeah, Dr. Archana from Jammu, I think I need to read this question. Sir, why do you need the child to be afebrile before the bronchoscopy? Won't we lose time, sir, in case of any underlying foreign body?
Yeah. See, foreign body in the tracheobronchial tray will not cause so much of fever. Yes, pneumonitis may be there and the fever may be there. But if the child complains, the child's predominant complaint is high fever, usually foreign bodies will not produce so much of fever. You have to think of medical conditions. After all, you can postpone your bronchoscopy for a while. There's nothing is going to happen unless you have a child with a history of choking, and when the child presents like this, see this history of choking is there, and the child has restlessness, then you do bronchoscopy. But for a patient who had a high fever with breathlessness, and there is no history of this patient, a very sick patient, see, high fever is there, no cough, child is so toxic, there is no history of aspiration, child has got severe respiratory distress. See this child is suffering from some medical condition. So I don't do bronchoscopy in such scenario. It's all tricky situation. This is nothing but acute laryngotracheobronchitis. Yeah.
But still, there are a lot of questions, but because of the lack of time, that we'll close this.
Yeah.
And before that, the last question, one question is that when there are a few questions, when you will conduct the next hands-on, and kindly do share the details.
Yeah, we will. We are planning to conduct. See, we do regularly conduct temporal bone dissection courses and live surgery ear courses in my place, but we have not, after that first course, we have not conducted the temporal bone. See, you can take a screenshot of this, and you can contact me you be in touch with me with the email. My mobile number also here. At this part, you can take a screenshot of this. See, when we conducted workshop on hands-on course, what we did, we allowed our delegates to participate on the rubber tube mannequin like this, and we gave sheep lung mannequin like this, and we gave flexible fibrous scope. We requested stores people. We did all these things. And we had a lot of didactic lectures on every aspect: anatomy, technique of bronchoscopy, anesthesia, complications. We had 10 lectures by eminent people. But that day we informed all pediatricians around in my town, about 250 to 300 pediatricians, to get a live, to conduct a hands-on course, it's okay. But if you want to conduct a live foreign body removal, it's not possible. You cannot get a patient on that day. So you cannot create a patient, or if the patient comes to me today, I cannot postpone the bronchoscopy till my course. So that is the reason I am not in favor of doing a live foreign body removal. But luckily, when we did bronchoscopy course on this day, we had a patient of tracheal foreign body, which we could show them live. We removed the foreign body that day live in front of so many people. It was well attended by across India. So many people had come. We will try to conduct this program in the days to come. Yeah.
So there is one doctor by name Dr. Sudhakar Ambalkar. Actually, I had not read the question earlier, and it is being insisted to be answered.
Yeah.
How much long will be safe if non-obstructing vegetable FB is there?
What's that?
How much long, that is time duration, will be safe if non-obstructing vegetable foreign body is there in this system?
See, vegetable foreign body per se, if it is smaller one, it will not cause obstruction, but it will produce, suppose if it is a vegetative foreign body like peanut, if peanut is nothing but fat, it produces a lot of granulations around the foreign body and secretions around the foreign body, and secretions below the foreign body will get accumulated. Then the child will start a lot of symptoms like cough, fever, and hemoptysis and other things. So we have to remove foreign body at the earliest possible time. We cannot wait till suppose if you don't remove the foreign body for a very long time, then what will happen is that the foreign body will produce granulations, and those granulations will become cicatrized, and there will be closing or partial closure of the tracheal wall or bronchial wall. Then you cannot insinuate your forceps and foreign body bronchs. So at the earliest possible time, you have to remove the foreign body. Yeah, I think I have answered your question.
Yeah. Dr. Kavita also wants to attend your hands-on course. And
Yes,
finally, there are appreciation from Dr. Brigadier Dr. J.R. Galgali from Pune.
Hi, sir. Galgali sir was my senior in my where we studied Dr. Brigadier Galgali and myself have studied at this institute. Both were alumnus of Command Hospital, Bangalore.
Yeah, likewise, there were a lot of appreciation from Dr. J. Samuel from Chennai, excellent presentation, and so on, so on. So since we have already 12:38, almost more than 1.5 hours, we will, sir, can you please share your contact number, sir, once again, so that when 1 or 2 times, so that when they can be, if at all, if there is any question, they can take.
Yeah, I will just type my number here. Can you see my number here? Hello?
Yes, sir, I am doing that.
I am typing my email ID.
Yes, sir.
Yeah, this is my email ID. If you have any doubts regarding purchase of any tracheobronch instruments, or if you have any doubts regarding anything pertaining to tracheobronchial foreign bodies or anything, please, you are welcome at any point of time. I am ready to give advice whatever I know. Thank you very much. I hope all of you are taking. Yeah.
Yes, sir. Yeah. Please continue. Yeah.
Okay. Thank you very much. If there are no questions further, we'll close the session, sir. Thank you very much. I thank CIPODEM people for taking this task, and it is an excellent show of CIPODEM, and I hope I have fulfilled your desires. I think I've done justice to the time that I have taken. Thank you very much, viewers and organizers. Thank you very much.
Yes, sir. I mean, I would like to extend my thanks for all the participants, and especially Dr. Reddy for the excellent presentation. I think there were a lot of questions and appreciations, so that itself it's a testimony for your presentation, sir. So once again, I mean, then many doctors are, in fact, they are very much interested in attending your hands-on workshop also.
Yeah,
And,
definitely. We'll inform
yes,
them.
sir. And in fact, if at all, if there is anything, then we can also sponsor some of the doctors who are interested when you are conducting this hands-on surgery.
Yeah, we'll be in touch with sir. Once this COVID issues are over, definitely I'll make it a point to again conduct this course, sir.
As a company, I mean, as an organization where we are very keen in improving and developing on the CME, I mean, this skills of the doctor, that definitely then we are very eager to participate in those type of programs and sponsor the doctors also who are really interested.
Yeah, definitely in
So
the
once
days
again,
to come, we'll do, sir.
And heartiest thanks to all the participants.
Yeah.
And once again, before that, then I would like to conclude that as a company, as a responsible, social responsible company, Sun Pharma is doing enough by more than enough. Or I mean, we would like to be continue to do social response to fulfill our social responsibilities. As already we are given 25 crores worth of this hydroxychloroquine, cipromycin, and sanitizers to most of the government hospitals, and still we are continuing.
Yeah.
And we will continue our service. And once again, we will also continue our educational service as well. So once again, big thanks to Dr. Reddy, and for big thanks to all the audience.
Thank you very much.
Very much. Thank you, sir.
Thank you,
sir. Thank you, sir.